We'll be exploring the medical uses of these central nervous system stimulants, diving into their pharmacology, the benefits they offer in treatment, as well as the side effects and patterns of misuse that present significant challenges. This presentation will give you a comprehensive overview of these important compounds, highlighting both their therapeutic value and the issues surrounding their misuse in society. Let's get started. Let's take a look at the historical background of central nervous system stimulants. It all began with the ancient use of the ephedra plant, which has been utilized medicinally by civilizations dating back as far as 60,000 years. This early use set the foundation for future scientific discovery. Moving forward to 1887, a major breakthrough occurred when ephedrine, the active compound in ephedra, was successfully isolated. This discovery was crucial because it allowed for more precise and effective medical applications. Then, in the 1930s, amphetamine-like drugs were developed as substitutes for ephedrine, marking the expansion of CNS stimulants. These developments paved the way for the modern drugs we use today, showing a clear progression from natural remedies to synthesized medical compounds. On this slide, we focus on the clinical uses and pharmacology of ephedrine. Historically, ephedrine has played a key role in treating asthma because of its bronchodilatory effects. Today, it is widely used to manage shock and hypotension, especially during anesthesia, thanks to its ability to cause vasoconstriction and increase blood pressure. Ephedrine produces peripheral adrenergic-like effects, which means it stimulates the nervous system in a way that increases heart output and opens up the airways, making it very effective for respiratory conditions. The chart here shows the relative frequency of ephedrine use across different therapeutic settings. As you can see, its use is highest in respiratory cases at 100%, followed by anesthesia-related hypotension at 60%, and then nasal surgery at 30%. In terms of administration, ephedrine can be given through various routes and is well absorbed, though it has a relatively short half-life. This means its effects are fairly quick but don't last very long, which is an important consideration when dosing in clinical practice. Overall, this slide highlights how versatile ephedrine is, especially in respiratory and surgical settings. Here we see a breakdown of the reported adverse effects associated with ephedrine use. The pie chart illustrates that autonomic side effects are the most commonly reported, making up 30% of cases. These include issues like urinary retention and heart palpitations. Gastrointestinal and central nervous system side effects each account for 25%, with CNS effects such as anxiety, insomnia, and tremors being particularly notable. Cardiovascular side effects, including palpitations and arrhythmias, represent 20% of reported events. It's also crucial to be aware of drug interactions. For example, when ephedrine is combined with tricyclic antidepressants, there can be a significant increase in stimulant effects, which poses additional risks. Because of these potential complications, consulting with a pharmacist before combining medications is highly recommended. The warning symbol here reminds us to exercise caution and carefully monitor patients when prescribing ephedrine. Here, we see the historical development of amphetamines, which were originally developed in the 1930s as analogs of ephedrine to address supply shortages. They became widely used during World War II, but due to issues with misuse, restrictions were later put in place. Moving to current times, amphetamines are now primarily approved by the FDA for treating ADHD and narcolepsy. They are also used off-label for managing conditions like depression and fatigue, showing how their medical roles have evolved but remain significant today. Here we see the differences in how amphetamines take effect depending on the route of administration. When smoked or injected, the onset is almost immediate, with the effect reaching high intensity within seconds. This rapid rise is followed by a quick decline, usually lasting just a short period. In contrast, the intranasal route, or snorting, produces a faster onset than oral use but not as rapid as smoking or injecting. It peaks around 20 to 30 minutes and gradually tapers off after a few hours. Oral administration has the slowest onset, taking 20 to 30 minutes to begin showing effects, but its duration is the longest, with effects lasting several hours. Pharmacologically, amphetamines work by increasing catecholamine activity, especially dopamine, by both releasing it and blocking its reuptake. This explains their clinical effects, such as enhanced attention and wakefulness, although side effects like irritability and insomnia are common. Understanding these differences in onset and duration is crucial both for therapeutic use and for recognizing risks associated with misuse. Here we see the reported side effect frequency of methylphenidate, which is primarily used to treat ADHD and narcolepsy. The most common side effect is nervousness and insomnia, affecting about 40% of users. This is followed by appetite loss, reported by 20% of patients. Although rarer, psychosis is a serious concern, occurring in about 5% of cases. Understanding these frequencies helps us weigh the benefits of methylphenidate against its potential risks and emphasizes the importance of monitoring patients closely during treatment. On this slide, we're looking at two important alternatives related to CNS stimulant treatments, modafinil and atomoxetine. Starting with modafinil, it's primarily a wakefulness-promoting agent used to treat conditions like narcolepsy and shift work-sleep disorder. Its half-life is around 15 hours, which supports its sustained effect throughout the day. Modafinil works by affecting norepinephrine reuptake, but it's important to be aware of its significant drug interactions, such as reducing the effectiveness of oral contraceptives and increasing the levels of warfarin, which means careful monitoring is necessary. On the other hand, atomoxetine is quite different. It's a non-stimulant medication prescribed for ADHD, acting by altering norepinephrine release rather than directly stimulating the CNS. One of its advantages is a lower potential for misuse compared to traditional stimulants, making it a preferred option for some patients. However, atomoxetine comes with a black box warning regarding the risk of suicidal thinking, which requires close attention from healthcare providers. Overall, these two medications highlight distinct approaches in CNS-related treatments, each with unique benefits and safety considerations. When prescribing CNS stimulants, there are several key clinical challenges that we must carefully consider to ensure patient safety. As shown in this chart, the highest levels of concern, both at 85%, relate to cardiac risk and the potential for psychosis. This highlights why thorough patient assessments are essential, including cardiac screening and detailed psychiatric histories before starting treatment. We also need to monitor growth closely, particularly in children, because about 60% of clinicians worry about potential growth effects. Addiction potential is another significant concern at 75%, reminding us to weigh the risks of dependence when deciding on stimulant use. Given these challenges, it's important to not rely solely on medication. Psychosocial and behavioral interventions should be considered as complementary or alternative approaches, especially since the evidence for long-term medication effectiveness remains limited. Careful monitoring of mood, vital signs, and overall development is crucial throughout the treatment process to manage these risks effectively. Let's look at the different ways these central nervous system stimulants are misused and who is most at risk. Amphetamines, for example, can be taken orally, snorted, smoked, or injected, with smoking and injection being the most common methods in the United States. Ephedrine is usually taken orally, and less often snorted or injected, while methylphenidate is misused mainly orally or by injection. Modafinil, on the other hand, has a lower overall misuse rate. However, it is often diverted for cognitive enhancement purposes. When we consider populations at risk, young adults and high school students show notable misuse rates, though this varies by region. Amphetamine misuse tends to be highest in North America and Australia or New Zealand. Meanwhile, in East and Southeast Asia, there is a rising concern around crystal methamphetamine use. Globally, around 27 million people use amphetamines, which represents a serious and ongoing public health challenge. Understanding these patterns helps prioritize prevention and intervention efforts where they are most needed. When we look at the challenges in CNS stimulant treatments, the first major issue is the evidence gaps. There is limited data on their long-term effectiveness and sustained benefits, so we have to be careful about how confidently we can recommend these medications over time. Moving on, individual variability plays a big role. Patients respond differently, with varying tolerances and side effect profiles, which means treatment needs to be highly personalized. Safety concerns are also critical. These stimulants carry risks of cardiac complications as well as psychiatric side effects, making close monitoring essential, especially for vulnerable groups like children. Finally, clinical priorities highlight the importance of thorough patient assessment and, whenever possible, favoring psychosocial approaches before relying solely on medication to ensure the best and safest patient outcomes. The balance scale image here really captures the careful weighing of benefits versus risks that clinicians must navigate. Here, we're looking at the scope and patterns of CNS stimulant misuse around the world. Young adults, students, and marginalized populations are particularly vulnerable, especially in regions like North America, Australia, New Zealand, and parts of Asia. These groups often face pressures, like academic demands and challenging social environments, that increase their risk of misuse. On the other side, the sources of these stimulants are important to understand. Misuse often stems from either diverted prescription stimulants or illicit methamphetamine labs. The prevalence of these sources varies by region, influencing how and where misuse occurs. The image here highlights Asia, emphasizing the geographical spread and regional differences in stimulant availability. Taken together, these points show the complex and widespread nature of CNS stimulant misuse globally. Here, we see how different routes of administration impact the onset and intensity of central nervous system stimulant effects. Intravenous use delivers the fastest and most intense effects, peaking right at the start and then rapidly declining. Smoking follows closely, with a similarly rapid onset but slightly lower peak intensity. Intranasal use, or snorting, produces a more moderate intensity, with effects building more gradually and peaking around 30 minutes. Oral ingestion has the slowest onset and generally the lowest intensity, with effects rising steadily and peaking later. These variations are crucial because they influence not only the user's experience, but also the risk of adverse effects. For example, faster and more intense effects from intravenous or smoked routes can increase the likelihood of toxicity and cardiovascular problems. Additionally, illicit substances may carry harmful contaminants, adding another layer of risk. Patterns like binging and developing tolerance further exacerbate these dangers. The key takeaway is that the route of administration significantly shapes both how quickly and how strongly the drug acts, which in turn affects the potential for harm. Amphetamine misuse has profound effects on the brain, starting with significant neurotoxicity. It can damage up to half of the dopamine-producing neurons and also harm the serotonergic systems. This happens through mechanisms like the release of free radicals and glutamate toxicity, which essentially poison these critical brain pathways. Moving on to cognitive effects, long-term use may impair memory and overall cognitive functions. Studies in imaging show structural damage in various brain regions, along with altered blood flow, which supports the observed decline in executive functions and memory performance. Then, we see serious psychiatric effects. Misuse can lead to psychosis, mood disturbances, anxiety, and depression. These psychiatric symptoms often persist well after someone stops using amphetamines, highlighting the lasting emotional toll. The brain scans here visually represent some of these changes, showing the areas affected by long-term amphetamine use. Together, these images and points illustrate how amphetamines cause complex, multifaceted harm, extending far beyond the immediate effects of intoxication to long-lasting brain and emotional damage. This slide outlines the extensive physical health impacts of amphetamine misuse on different organ systems. Starting with the cardiovascular and cerebral effects, misuse significantly raises the risk of heart attacks, irregular heartbeats, severe hypertensive crises, and strokes. Additionally, individuals who misuse amphetamines are far more likely to develop cardiomyopathy, which can severely weaken the heart muscle. Moving to the pulmonary and digestive systems, users often experience lung complications like edema and infections, which can worsen respiratory conditions such as asthma. On the digestive side, there are serious problems like ischemic colitis, where blood flow to the colon is reduced, causing tissue damage. A particularly visible and distressing consequence is severe dental decay, commonly called meth mouth, shown in these illustrations. Lastly, other organ systems are also affected. Methamphetamine misuse can cause liver damage and rhabdomyolysis, a condition where muscle tissue breaks down rapidly, potentially leading to kidney injury and other complications. Altogether, these effects show the widespread and severe damage amphetamine misuse causes throughout the body, highlighting why it's crucial to address and treat this issue comprehensively. Here we see a comparison between methylphenidate and modafinil regarding their medical use versus diversion for illicit purposes. The donut chart clearly illustrates that methylphenidate has a higher proportion of diversion, with 25% of its use being non-medical, compared to only 10% for modafinil. This is significant because methylphenidate is often misused not just orally, but also by snorting or injecting, which greatly increases the risk of addiction due to its strong effect on dopamine transporters. Modafinil, on the other hand, is typically linked to lower euphoria and misuse potential, but concerns are growing as it's being diverted increasingly for off-label cognitive enhancement, with potential risks of drug interactions. Understanding these patterns is crucial, and it highlights the importance of harm reduction strategies like secure medication storage and careful prescribing to limit misuse and protect patient safety. When diagnosing stimulant use disorders, the key requirement is that the individual meets at least 2 out of 11 specific criteria within a 12-month period. These criteria include factors like tolerance, hazardous use, withdrawal symptoms, and continued use despite problems. Additionally, modifiers such as remission status or whether the individual is in a controlled environment help to further clarify the diagnosis. The severity of the disorder is then determined by the number of criteria met. If 2 to 3 criteria are present, it's classified as mild, 4 to 5 indicate a moderate level, and 6 or more reflect severe disorder intensity. This scale helps clinicians tailor treatment approaches based on how deeply the stimulant use has affected the person. One of the biggest challenges we face is that symptoms induced by stimulant use often closely resemble those of primary psychiatric disorders, such as depression or schizophrenia. This overlap can complicate diagnosis and treatment planning, making it critical to conduct a careful and thorough differential diagnosis to ensure the patient receives the appropriate care. Here we have a summary of the most important points about CNS stimulants and where future efforts should focus. First, these medications have clear therapeutic benefits, especially in treating narcolepsy, ADHD, and certain respiratory conditions, providing significant clinical improvements. However, they also carry major risks, including notable side effects and a potential for misuse, which means careful management and monitoring are essential. Despite their use, there remain important gaps in our understanding, particularly regarding the long-term effects and the safest ways to treat stimulant use disorders. More research is clearly needed here. Clinically, it's recommended that psychosocial interventions be prioritized alongside cautious pharmacological use, as counseling and behavioral therapies often lead to better outcomes. Looking ahead, the emphasis is on improving diagnostic accuracy, developing harm reduction strategies, and creating safer medications, all aimed at enhancing both patient safety and treatment effectiveness. The light bulb image symbolizes innovation and insight, reminding us that ongoing research and new ideas will drive future progress in this field. Now, I'd like to open the floor for questions and discussion. One of the key challenges we've touched on is finding the right balance between the benefits and risks of CNS stimulants in clinical practice. How do we ensure patients receive effective treatment while minimizing potential misuse or adverse effects? Another important point involves clinical pathways. How can we best monitor and support patients who are at higher risk when using these medications? Lastly, there's the broader policy perspective. What approaches can help address the public health concerns related to diversion and misuse? I encourage you to share your thoughts and questions so we can explore these complex issues together.